Okay, so that was one example of these interacting contingencies, or hierarchical or cascading contingencies, where the different levels interact with each other. What I'm now going to share with you is another example of how these networks interacted with each other, or different levels interacted with each other across international borders. So I conducted, for a number of years, research related to tuberculosis along the US-Mexico border. Now, if you have tested positive for tuberculosis, the recommended treatment from the Centers for Disease Control and Prevention is that you undergo 9 months of treatment with an antibiotic called isoniazid, or INH. If you've ever seen somebody that was born in a developing country, you may have noticed, and if not, you may notice in the future, a little bump on the side of their arm, just below their shoulder. This is usually a little scar. It's not very big, but can be quite noticeable if you know what you're looking for. This is the result of the BCG vaccine, which is given primarily in developing countries and provides short-term immunity from certain strains and certain types of tuberculosis. It does not provide lifetime immunities. This is not a vaccine in the typical sense that once you have it, you're protected for an extended period, perhaps even life. So this is not it at all. This provides some temporary protection. Well, this is not well understood in many parts of the world, and so many people believe that it not only protects you from tuberculosis, but it also causes a positive skin test. Well, again, the Centers for Disease Control and Prevention, after years and years of research, has said that indeed this does not cause a positive or a significant skin test reaction. So it may cause a small reaction, but would not be measured as significant. And so what their recommendation is that if you have a positive skin test that is deemed to be significant, that you be treated independent of whether or not you ever received the BCG. Well, so let me first discuss Network 1 on the far left-hand side. And this relates to our laws and policies in the United States. So, for example, if you have in the United States an adolescent that wants to volunteer at a high school or wants to attend one of the colleges along the border, then you would be required to have a tuberculosis skin test. If you tested positive for tuberculosis, you'd need a chest x-ray to rule out active tuberculosis. And you would also have to undergo treatment. So even if you didn't have active tuberculosis, you'd have to undergo treatment. That's our law in the United States. So if you are living here in the U.S., you can think of this in an ecological framework. That's our policy that trickles down all the way to the individual level. And so in our research, we determined that there were a lot of kids, indeed thousands, that signed up for the free tuberculosis screening because, as per the laws and policies in the U.S., this had to be done. So we had thousands of kids sign up for a tuberculosis screening. And we determined that the prevalence rate of latent tuberculosis infection was about 18 or 19%. And so of the thousands of kids, there was a pretty significant number that were tested, hundreds of kids that tested positive for tuberculosis infection. So so now we're moving into Network 2. As a result of Network 1, now we're moving into Network 2. And if you're a young Latino living close to Mexico, and you test positive for tuberculosis infection, and you don't have health insurance, you're most likely, and this is what happened at least in our research, most likely to go to Mexico to get treated, because you can do so for just a fraction of the cost of being treated in the United States. And you may actually be more comfortable interacting with that medical system. So what we found is that many kids traveled to Mexico with their positive results. So they got a sheet from the county of San Diego, and they went over to Mexico to a provider. And they said something like, I tested positive for tuberculosis in the US, and I need to be treated. Because in order, again, to progress and to continue in the United States, you have to be treated for tuberculosis. So they would go over there and say, I need to be treated. Now, the common train of thought for most providers in Mexico would be that you don't need to be treated because it's the result of the BCG vaccine. But again, we don't adopt that perspective in the United States. But that is, or at the time, was the common train of thought in Mexico, and particularly in Baja, where Tijuana is located. So providers would say, oh, don't worry about it. You're okay. You're just fine. So because that was the structure there. And so then they would come back to the U.S. and they would say, actually, my doctor in Mexico said I don't need to be treated. He said, I'm just fine. Our response was, and this is a collective R, meaning our policies here, was we don't care what your doctor in Mexico said. Our laws in the United States state that you need to be treated or you need to be treated for tuberculosis. So then this caused adolescents to have to return to Mexico and say to their provider again that I need to be treated. And the provider again would say, don't worry about it. And so this process went on several different times. And finally, the infrastructure, the policies that became most important to them were those in the United States, because that's ultimately where they wanted to spend their professional career, get a job, and go to school and things like that. And so eventually the policies in the United States became those that were most powerful for them. And so then we had patients going back to Mexico a third, fourth, and fifth time, demanding of their providers that they be treated for tuberculosis infection. So you'd have providers saying, no, it's not necessary, but ultimately a patient was so assertive that they said, I absolutely want to be treated. I know you don't want to treat me, but I want to be treated for it. So you had providers recognizing that if they didn't treat this patient, they would go somewhere else, and so the provider would lose a client. And so what happened was, over time, and we kind of measured this unofficially, we had over time where providers would now be providing this treatment to patients, and then the providers probably started talking with each other. So now we're not just moving top down, but now we're moving bottom up. And so we had individuals being assertive and demanding these things. Providers start talking with each other at the local level, interacting with the community. And so then these providers interacting with community clinics, and we actually measured this impact by, at the end of our research, we called community clinics in Mexico and said, what is your policy related to tuberculosis infection? And we believe that it changed because when we called it follow-up, a lot of the clinics said, we now have a policy that we will treat all cases of positive skin tests. So this is a perfect example of how behavior change works both top-down and bottom-up, and how these different levels interact with each other. Now, the last example that I want to share with you related to these interacting contingencies, or hierarchical contingencies, as Hubble might refer to them, relates to the California Tobacco Control Program. Now, the California Tobacco Control Program represents perhaps one of the greatest examples of a comprehensive ecological intervention. So there was a tobacco tax initiated, and so that represents a policy or societal level influence. There were media education programs, and those might represent community level operations, sting operations where they would test to see and try and identify vendors that were selling illegally to minors. Public school education programs, now these might be targeting attitudes, perceptions, beliefs at the individual levels. Quit lines, a lot of research going on, and then again legislation banning smoking in public buildings and eventually public parks and other places. And so this is very comprehensive in the sense that it's addressing a lot of the different levels of the ecological model. So my colleagues initiated a study to measure whether or not this interacting and hierarchical contingencies might be at play. And so they initiated a study that they called Santigua, meaning San Diego, Tijuana, and Guadalajara, Mexico. Now, the stars that you see on the map here have actually shifted a little bit for some reason. I don't know why. So it looks more like Los Angeles and a little higher than Guadalajara, but really they should be shifted down a little bit to represent San Diego, Tijuana, and Guadalajara, Mexico. Now, obviously, as you look at that map, it will become apparent to you that San Diego and Tijuana are very close to each other. In fact, sometimes they're referred to as sister cities, as it's really one continuous metropolitan area. Separated by an international border. Nevertheless, it's highly populated and very continuous. Guadalajara, of course, is a long ways from either San Diego or Tijuana. So what they were interested in studying, and this was Hovell, what he was interested in studying was the interacting contingencies, meaning these different levels. Would they be stronger? Would the influence of the California Tobacco Control Program be stronger in San Diego, in Tijuana, than in Guadalajara? Because of course we hypothesized that it would be strongest in San Diego, because indeed that's where the California Tobacco Control Program was focused, in the state of California. Tijuana is not in the state of California. There were no public funds